Right, well, we could get started. I'll make some introductions. We look to be stable with our numbers, but if people continue to join, we'll do some introductions first to give them time to join us. Hello, everybody. My name is Amy Blanco. I am a genetic counselor. I'm the director of our Cancer Genetics and Prevention program at UCSF, and colon cancer has been a passion of mine for going on 20-some years. So thank you for joining us in celebration or recognition of Colon Cancer Awareness Month, which is all of March. So welcome to Colon Cancer Awareness Month. Today, we're going to be talking about all of the ways that we can screen for colon cancer and reduce our risk for colon cancer through screening. We will be spending the first half of the webinar tonight reviewing some educational materials. And then we will have a question and answer session where we would love to hear about all your questions on this topic, and we'll do our best to answer them in real time. So I'm going to go ahead and introduce our first speaker. Our speaker today is Dr. Appy Singh, and Appy is a gastroenterologist who is the director of UCSF's GI Cancer Prevention Program and the new Lynch Center at UCSF. Appy is the Quality Improvement Director for the Division of Gastroenterology as well, and she has a strong interest in colon cancer prevention and quality colon cancer screening. Dr. Singh's background is she has a Master's of Public Health from the Johns Hopkins University. She did her fellowship in gastroenterology right here at UCSF and did her residency at the Cleveland Clinic. And we're really lucky to have her on our team. We will have some moderators for the Q&A session today, myself, as well as Sarah Ertan, who is a genetic counselor and the lead genetic counselor in the Lynch Syndrome Center, as well as Dr. Jonathan Turdeman, who's a gastroenterologist and the professor and chief of the GI division at UCSF. We will also hopefully have Dr. Michael Potter, who is a physician of family medicine and is the co-lead of SF-CAN's Colorectal Cancer Task Force, and is a board member of the California Colorectal Cancer Coalition. So we'll be taking those questions after Dr. Singh provides some educational content. Thank you again for joining, and welcome to Colon Cancer Awareness Month.
Thank you so much, Amy, for this kind introduction. And I would like to welcome everyone again. Thank you for spending your evening with us as we celebrate and recognize Colon Cancer Awareness Month in March. And I'm really honored to speak about my passion, which is colon cancer prevention. So let's get started. So what is colorectal cancer? So colorectal cancer is cancer of the colon and rectum. So for the purpose of this talk, when we say colorectal cancer, for screening purposes, it means the same as colon cancer. For management-wise, colon cancer and rectal cancer, they could be different, but when we talk about screening, we pretty much mean the same. So colon is a long 5 to 6 feet long tube. Here is a cartoon to show you. It's a inverse U-shaped structure, and the lowest end here is called rectum. And the tube here, where it ends and attaches to the small bowel, that's where, as far as the colonoscopy goes, and we talk about colon cancer. So burden of colorectal cancer. How common is it? I hope I can convince you that it is a very common cancer and a big problem. 1 in 25 individuals in this country will be diagnosed with colorectal cancer in their lifetime. This is a significant statistic for us to remember. It is the third most common cancer in men and second most common cancer in women. 75% of people who died of colorectal cancer were not up to date with screening in latest statistics. And what we have found that 25% of colorectal cancer is diagnosed after the cancer has metastasized, which means it has spread to other organs. So these numbers are very concerning to me for a cancer which is potentially curable and very preventable. We should not be diagnosing advanced stage colorectal cancer that should be detected early and prevented with so many options we have today. So let's look at the scorecard. How are we doing with colorectal cancer screening? Unfortunately, not good. We have seen data that 40% of adults age 45 and older. So these are the people who should be getting colon cancer screening. And 40% of those are not up to date, are falling behind. They either did not have it or they are not up to date. And then we have also seen many studies that show that there are many misconceptions and misinformation around colon cancer screening. And that leads to poor adherence. And my goal today is I hope we can talk about some of those and talk about those myths and misconceptions and educate everyone. So, what are the symptoms of colorectal cancer? One of the commonest symptoms I see in my practice is patients are often surprised. How could I get a colon cancer? I feel perfectly fine. So, one of the most common symptoms, even for a very advanced cancer, is nothing. You may feel no symptoms, no bleeding, no pain, and you may have, early stage or sometimes even advanced stage cancer. Many a times when these cancers cause symptoms, they can cause blood in your stools or a feeling of incomplete evacuation. So something is stuck down there. And you see sudden change in stool shape or frequency. So you used to be once a day person for bowel movement, and suddenly you're going 4 times a day. And I tell my patients it should be a change that's not just for one day, it's persistent over days and weeks. That's when you start worrying about. You have unexplained weight loss without trying, unexplained persistent pain in your belly, pain in your back because tumor cells have, invaded various organs. So multiple symptoms can present based on the cancers and their location. So early detection is the key for colon cancer. Here you can see that if you find a colon cancer or colon growth in a polyp phase, you can just do colonoscopy and remove the polyp, and you prevented a cancer from even starting. Colon cancer is one of the unique cancers where you can prevent it by interventions. For example, in breast cancer, you do mammography, which is very important. But with mammography, you are trying to detect a cancer. Unlike that, in colon, there is a precancerous phase where you can intervene. You can remove a precancerous polyp and stop it from turning into a cancer altogether. Here you can see in this image, the first image A is a small colon polyp. If you do not remove it, it grows into this large colon polyp, doesn't look good, and then the image number C does not need me to explain, has turned into a cancer. This, if intervened early on at image 1, was preventable. So also, early stage cancers, if you detect at early stage, you can just do a surgical resection and you can be cured. If the cancer has advanced, it has spread to lymph nodes, it has spread to other organs like liver, lungs, then you need surgery, chemotherapy, radiation, and perhaps more surgery to remove the lesion from your liver, your lung. And all of this would have been a lot easier if early interventions were done. So here is a table to show you that early detection improves survival. What are the numbers? So a very rough estimate here shown, if you detect colon cancer at stage 1, which is confined to the colon and rectum, the 5-year survival, so odds that the person will survive 5 years is excellent, is more than 90%. If the cancer has gone to deeper layers, so stage 2 and stage 3, which is deeper layer of the colon wall and the surrounding lymph nodes, the survival at 5 year drops to 73%. So, 20-30% of those individuals will not make it to 5 years. And the numbers drop very significantly if it is stage 4 colon cancer, which is a cancer spread to distant body parts we discussed, and the 5-year survival is 15% only. So about 85+% of these individuals will not make it past 5 years. So significant differences based on the staging. So now that brings us to the question. So when to start screening, and take home from this talk is age 45. If you are 45 years and above, you should be getting screened for colon cancer. That is for, we call it average risk person. So meaning if you have no family history or other risk factors, anyone. So that age 45 is regardless of your gender, regardless of your ethnicity. We do not make different screening recommendations based on those. We do see variability in the risk. Like, for example, African American, some population may have higher risk of cancer. But as of now, despite the variabilities, the risk is significant enough, regardless of gender, ethnicity, background. Everyone in this country, we recommend starting colon cancer screening at age 45. So when should you start it sooner? So that is, if you have a close family member, so that is your parents, your siblings, or children, if they have a history of colon cancer or a large colon polyp in them as well, we have seen in our studies that the risk is, if one person has it, the other person, the blood relative, the risk goes up. And those individuals should start screening at age 40. So we talked about 45 for everyone, but if your mom had a colon cancer, your dad, sister, brother, you should be starting at age 40 or 10 years before they had it. So for example, your sister had a colon cancer at, let's say, 39. So you should be starting 10 years before them. So for you will be actually at 29. So start at age 40 or 10 years before the youngest age of cancer diagnosis in the setting of family history. Otherwise, start at 45. So how do I get started with colon cancer screening? So now you are 45 and above, you need to get screened for colon cancer. What are the options? So good news, there are too many options now. Excellent, safe. Number one, everyone knows here is colonoscopy. There are stool-based tests as well, like FIT test and Cologuard, which are commercially available. A third one coming soon is ColoSense. There is now an exciting blood test as well, known as Shield blood test for colon cancer screening. And the fourth one is a virtual colonoscopy or CT colonography. There are some other options available as well, which I'm not going to talk about because I want to focus on the take home and the ones that you should be considering in your routine care. So if we look at this cartoon, here we can see that colon polyps, you can see they start small and they gradually grow to the deeper layers of your colon wall, and they shed various markers. and that's what we use for detection. So one is you can do colonoscopy, go straight in the colon, take a look. Simple. The other options are these growths will shed some markers, exfoliation in the colon. So you can catch that in your poop. That will be the stool testing. And these growths also have micro markers going in the blood. And then you can do a blood test to catch those markers for screening as well. So here you can see if the polyp is really small in the wall, it's not going to shed many markers in the stool or in the blood. So that will explain why small polyps are hard to detect on blood tests or a stool test. However, a colonoscopy will detect most of the lesions. So let's talk about colonoscopy. That is something, very routine. I have done many, many thousands of those, very commonly done and very safe procedure. So a few highlights about colonoscopy, lots of myth around that's being uncomfortable or, painful procedure. That's not really true. So colonoscopy, generally, it's a 20 to 30 minutes procedure. You change your diet a day before. Generally, we used to say to go on a clear liquid diet, which is like having like an apple juice or a transparent juice kind of diet. Latest studies have shown that that you don't really have to do that. You can have a low fiber food. Examples of that are a white bread, white pasta, some eggs, yogurt. So these are called low fiber food. And the goal is if you eat some low fiber food a day before your procedure, you do not really make a lot of poop. So when you drink the laxative to cleanse you, it's not that hard. And we have found in the studies that in patients who are not super constipated or have a very slow colon, even if they have a low fiber food a day before, the prep is equally good. So many of, our practice has been to be on a clear liquid diet. At UCSF, we do have option of taking a low fiber diet prep. So feel free to discuss with your endoscopy providers if that will be an option for you. As I have noticed that many people do not want to do colonoscopy thinking that they have to starve for a day. Doesn't have to be the case. So then when you prepare for the procedure, you drink the laxative. It used to be 4 liters of Golightly in the past, and good news on that as well. We have many options available now for bowel prep. Some are as low as 2 liters of bowel prep. And we also have pill-based laxatives available as well. So the volume you drink is a lot smaller than it used to be. So experience for the preparation can be a lot smoother than what we had, many years ago in the past. For the procedure, you just need to take 1 day off work and you come to the procedure. It takes 20, 30 minutes to do the procedure. You're sedated. So you receive some form of sedation or propofol anesthesia by your providers. You're sleepy and comfortable. The test is done. If they see any polyps, growths, they'll remove it. The benefit is if there is a colon cancer, a growth seen, it can be biopsied as well at the same time for confirmation. And most of the time, we just see polyps. We can remove them and send them for pathology. And you're back to work next day. So it's a safe procedure. Complications are super rare, and they generally happen if you have a really large polyp, which your endoscopist is trying to cut and slice off, and that can increase your risk of a puncture or bleeding that is generally associated with larger polyps. So here a message could also be that earlier colonoscopy in a timely fashion, when we can catch the polyp at a smaller stage, it's a lot safer. I would have, will be almost never to have someone have a puncture with a 2 millimeter, 3 millimeter tiny polyp. However, the risk goes up if you have a centimeter, 2 centimeter polyp. being removed. So I'm sorry if it's your dinner time, but I had to include this image that bowel preparation is important for your colonoscopy. First image is a clean bowel prep, and your endoscopist's performance depends a lot on how clean your colon is. If just a bile is coating the colon, even that can make the colon, examination of flat polyps really hard. So really pay attention to the prep instructions so that you do not have to repeat the procedure at a sooner interval. So here again to show you that colon polyps, they are growth in the colon and they all come in different shapes and sizes. So just having that I had a colon polyp is not enough information. Try to understand how large was the polyp, what was the pathology of that. There are various types called precancerous, like tubular adenoma, sessile serrated adenoma. And from the small size to large polyp, it can take 5 to 10 years to turn into a cancer. So removing the polyp at an early stage can prevent that cancer. The larger the polyp, it can turn into a cancer sooner. And here again, just to show you in here, a top image that this is a polyp, very, very flat. You can barely see it. It's like a sticker on the wall. And so a careful examination is really important. If you're coming out super fast, if the prep is not really good, you can miss those flat, subtle lesions, but they are precancerous with a potential to turn into a cancer. All right, so we talked about colonoscopy, which is the gold standard for colon cancer, detection, and as we said, prevention. No other test has the prevention aspect, but they all have good performance as well. So after colonoscopy, the second test we commonly done is a stool fit test. So I'm sorry for this is a very busy image here, but this is from UCLA. I love that it has all the instructions to guide you how to collect a stool sample for fit test at home. So it's super easy test. It looks for a small amount of hidden blood in your stool. So we saw the image for polyps and cancers shedding tiny amount of blood, which you can detect in your stool. So no diet or medication changes or laxatives, no preparation needed at all for a fit testing. You just take the kit home, collect a tiny sample, and send it to the lab. That's it. But remember that if you do a fit test, you have to repeat it once a year. And if it's positive, you will need a colonoscopy. So now that was a stool test. And now moving on to a stool Cologuard test, which is also known as multi-targeted stool DNA testing or fit DNA testing. So Cologuard is it's an excellent test for colon cancer detection as well, and it tests for stool DNA, multiple markers, so multiple mutation markers, and also tests for fit. So it is testing for fit along with some other markers. So you can see that will make this a lot more sensitive test. Even for Cologuard, easy breezy to do that. No dietary restrictions, no medications restrictions necessary. You eat what you want, you take the medication you want. The difference in patient experience for Cologuard versus FIT is in Cologuard, you can see the collection kit is a whole box. So instead of a tiny swab, you do in FIT test, you need a larger amount of stool sample collected, and then you send it to the lab yourself for testing. And if Cologuard is positive, you need a colonoscopy. And again, unlike colonoscopy, Cologuard is for detection of large polyps and cancer. It is not for prevention of colon cancer. All right, so we talked about, stool test, and then, there in a few minutes, I will also discuss some blood tests as well. So I do want to discuss the sensitivity for these tests for detection of colon cancer and also advanced polyp. So here you can see that, I'm sorry, it's a lot of numbers, but just to simplify that, a stool fit test is, among these three options is the cheapest. Cologuard is a couple $100, and Shield test is several $100. These are all FDA approved, so should be covered by many of the insurance plans. So a stool fit test will detect a colorectal cancer 75% of the times. So many will be missed. And how often will it detect an advanced polyp? So advanced polyp is a large polyp, a centimeter or more. So just 23% of the time. So it will miss 75+% of the advanced polyps. How about stool Cologuard? So Cologuard will detect 95% of colon cancers. That's great. However, it will only detect 43% of those large polyps we talked about. And the blood test that we will discuss is a new option that will detect a colon cancer about 83% sensitivity. So 83% of the colon cancers will be detected. And it doesn't do that good a job for advanced polyp detection, just 13%. So here you can see that all of these tests have their pros and cons, like how expensive they are, what's their, how likely they are to catch a cancer or a polyp. It varies for various tests. So the Shield blood test, I promised you, let's talk about that. So it's the newest, one of the newest blood tests FDA approved. We are excited about. It was approved last year, July, and it's based on a large study called Eclipse study, well-designed trial. And what, we discussed the sensitivity of cancer detection and polyps as well. The blood test experience, the biggest advantage of this Shield blood test is it's super easy to do that. That's where it is. It has a plus. Doesn't do a great job of detecting the cancer of polyps compared to many other tests, but the experience is, it says you go to a lab and you give, a blood sample, as easy as that. That's it. No change in diet, no laxative, nothing. And again, a positive test will need a colonoscopy for this as well. And like other tests, Shield does not prevent colon cancer. It is for detection of a cancer. So limitations, we talked a little bit that, in that trial, they found that even stage 1 colon cancer, it did not do a great job of catching them, but it does a better job of the more advanced the cancer, more likely they are to be detected by this test. It, as we discussed, doesn't do a good job of detecting the large precancerous lesions. And so where do I place Shield test? What's my recommendation? So my recommendation for placing Shield will be, if you cannot do a colonoscopy, if you cannot do a stool test, then you could consider a Shield test. So any screening is better than no screening, is the key message here. So this will have a role in very small fraction of patients where none of the other tests are acceptable to them. Okay. So now a little bit about a new test which is not commercially available is a stool ColoSense. This is a stool RNA and fit marker test. It's FDA approved and it's not yet available to be ordered. But it does have the data are really promising. It improves chances of detecting cancers and polyps. So we remain excited this as another option to be available hopefully soon. All right, so what else we have in our toolbox? CT colonography or virtual colonoscopy. I don't use it routinely, but we'll talk a little bit about it. The CT colonography is, taking some laxative to cleanse your colon. And after that cleanse, the amount of cleanse is a lot smaller than what you do for a colonoscopy. So you take the little laxative, and the experience is just like you go for any CAT scan to a radiologist. So you go for the CAT scan, you're fully awake. So no risk of sedation for this virtual colonoscopy. They place a tiny tube in the rectum and inflate your colon, because a collapsed colon, it's really hard to see any growth inside. So once they do the inflation, here you can see, if you can see the arrow on image B, there is a polyp or a cancer here. A large growth can be seen here. So CT colonography does a really good job. Here you can see when this person undergoes colonoscopy, they see a big mass in the colon, which is the colon cancer. So it's a great test for detection of colon cancer, pretty much as good as a colonoscopy or even large polyps. But why don't we use that in common practice? One, if it sees a cancer, it's not going to biopsy it. You still need a colonoscopy to biopsy the lesion for confirmation. And it's radiation. So that exposure is there if you do it repeatedly. And so where I place in my practice is if I get asked to do a colon cancer screening in a person who is about to get a heart transplant and they never had a colonoscopy or any other screening, they're too sick to undergo colonoscopy, I may just send them for a virtual colonoscopy. And that gives me I'm very confident after that do not have a colon cancer, they can proceed with their heart transplant, lung transplant. So generally, I use it in patients where I feel that sedation is risky for them, but they still need some form of colon cancer screening. Other than that, I do not place that for routine use in average risk population, given the risk of exposure. And, the other thing we worry about is it may find small, findings that may cause a concern or anxiety. Like, what if it shows a tiny bleb in your cyst, cyst in your spleen, a tiny thing, growing in your some other organs? What would be consequences of chasing something benign? Would be a disadvantage as well. So we talked about multiple modalities for colon cancer screening. It's really important to stay up to date with the screening. So I see many patients, they come and say they had a stool fit test, 5 years ago, and they haven't done anything since then. So it's really important when you choose a test that you decide how often you need to repeat that and you are following along. Doing it just once and not doing when you're due makes you again fall behind the schedule and the risk goes up. So if you have a colonoscopy, you are average risk person and it's completely normal, great news, repeat in 10 years. However, if polyps are found, discuss with your physician, what's the size, what's the pathology, and based on that, they may ask you to come back in 3 years, 5 years, there are well-defined algorithms for that. If you choose to do a stool fit test, remember that needs to be repeated every year. So it's a once-a-year test. If you choose to do a stool Cologuard test, that needs to be repeated every 3 years. Some societies even say they should be repeated, every 1 to 3 years, but general standard is repeating them every 3 years. If you choose to do the blood shield test, that should be repeated every 3 years as well. It's one of the newest tests, as I shared. We'll learn a lot more about it as more data evolve. And also, it's really important that you know that if you do a fit test, a Cologuard, a Shield, or a virtual colonoscopy, if they're positive, you do need a colonoscopy follow-up. So if anyone who does not want to do a colonoscopy ever, then doing a Cologuard is just be mindful. If it's positive, it's a way for you to go to a colonoscopy. So, when to choose colonoscopy where other stool or blood-based tests? So there are certain situations where we suggest that the stool test and the blood test are not really for you. For example, if you are a person you had precancerous polyps before, then you should stay in colonoscopy cycles because you are considered high risk. So I wouldn't do a Cologuard or FIT test for that person based on current data. If you have a family history of colon cancer, you should be choosing colonoscopy as your screening option. If you have, Lynch syndrome or other genetic syndromes, have Crohn's disease, colitis, colonoscopy is the preferred test. I would just add here briefly that there are some trials going on to study the stool test and others in these high-risk population as well, but we're not there yet. So on the same note, we discussed about starting colon cancer screening. So when should you stop colon cancer screening? The short answer is whenever you are too sick with other medical issues that your life expectancy expected is less than 10 years. Then there is not much benefit of doing a routine colon cancer screening. So generally, we do screening colonoscopy. If it's normal, then we stop at age 75. However, if your earlier colonoscopies, they had some polyps, then we can keep going with colonoscopies until age 85, as long as you stay in a good health. So if you are, you have made some polyps, you are in great shape at age 80, playing golf, walking a couple of miles a day, that person, will happily do a surveillance. We call it surveillance colonoscopy, and we do until age 85. After that, there is not much value in doing any of these procedures, and we worry that, they can cause some harm as well with sedation and other procedural interventions. So I have to mention something very close to my heart is when should you discuss genetic testing with your providers. So as many of the attendees here would know that 1 in 300 people in general population have Lynch syndrome, which is a genetic alteration that causes a significant increase in your risk of colon cancer, uterus endometrial cancer, and various other cancers. So how would you know that your family history is concerning? So if you have multiple members with cancers in your family, and many of those were, young age colon cancers or uterus cancer, you should discuss with your medical team if you should be getting genetic testing. You can meet with the genetic counselors. They can help you decide and order genetic testing for you. I'm proud to share here that, my team here, Amy, Sarah, and others, we have worked on a calculator called UCSF Lynch Syndrome Center Hereditary Cancer Risk Calculator. We can share the link with you in the chat box. So you can go to the center website and click on the cancer risk calculator. This asks you a few easy questions about your family, and it can give you an output in the end if you meet NCCN, which is National Comprehensive Cancer Network's criteria for 2 most common hereditary cancer risk syndromes, which are Lynch and BRCA. It guides you if you should discuss genetic testing with your providers. So I encourage you all to check it out. And it will be important for you to know if you have those mutations, like the multiple cancers in your family are because of those mutations. It will help you in your management that if you, let's say, if you do have Lynch and you wait until age 45 to get colonoscopy, it's too late. Individuals with Lynch start screening colonoscopies depending on their gene as early as age 20. So, and we repeat those colonoscopies every 1 to 2 years because those cancers can grow really fast, and we don't wait 5 years, we don't wait until age 45. All right, so now moving on to a little bit about young onset colorectal cancer. So you all must have heard on news and social media, like, we don't know what's going on with these alarming increasing trend of colorectal cancer, and actually various other cancers as well in young people. So these are individuals in their 20s, 30s, early 40s. So the current screening guidelines do not even cover them. We start at 45, but we are seeing a lot of cancers, late 30s, early 40s. So how you can use this information is if you have symptoms. So the symptoms I discussed earlier, if you are experiencing any of those and they're persistent, discuss with your primary care physician. In the beginning, they should be doing a rectal exam, because many of these colorectal cancers are distal they are in the lower part in the rectum. So they can sometimes, be palpated. You can feel it during your digital rectal exam as well. And then if symptoms are persistent, they should, you can discuss if you should be getting a colonoscopy, even if you are younger than 45, if you develop symptoms, to look for young onset colon cancer. I will share a caveat that many of the symptoms I discuss, they can be seen even without colon cancer for various common conditions. So having a good discussion with your physician to assess your risk is really important. So what are the risk factors for colorectal cancer? What causes it? Various things. We don't have one word answer for that. Age is the most common. We can't do anything about that. As we age, the chances of getting cancers go up. If you had polyps in your prior colonoscopies, stay on the schedule for follow-ups, because those are the patients, your body is telling you you are at higher risk of making more polyps, and they can grow and turn into a cancer. We discussed, if you have family history, that's high risk. Obesity, smoking, one of the most important one, excessive alcohol intake, inflammatory bowel disease like Crohn's disease, ulcerative colitis, diabetes, sugar sweetened beverages, processed meat, red meat, excess, processed Western diet, and excessive intake of antibiotics during childhood or pregnancy, causing alterations in microbiome. And some people, if they had a cancer in childhood and that was treated with radiations, we are seeing that when they are in their 30s, 40s, higher risk of colorectal cancer in them as well. So some common questions I get asked in my practice is, I had a polyp before and had a colonoscopy. I heard about Cologuard. Can I just do that? So as we discussed, Cologuard and FIT test, even the Shield blood test, they are for people who are average risk, meaning they have no family history, they have no symptoms, they had no polyps. So for average risk routine, not for patients who had past polyps. And the secondly, I get asked is, I had a normal colonoscopy. My doctor asked me to come back in 10 years. I have no other risk factors. Should I be doing a Cologuard or a FIT test in between? As of now, we do not think that is necessary. You had one normal, great quality colonoscopy, great. You should come back in 10 years. Nothing required in between unless you develop like some symptoms. So some colon cancer screening myths, again, like, many patients I see, when I diagnose with colon cancer, I hear of some myths that, oh, I did not do screening because nobody had colon cancer in my entire family. I did not think I will get that. It's a myth. Not having family history doesn't mean you do not have risk. Or say that I belong to a certain race and ethnicity, it doesn't happen in my race or ethnicity or my heritage background. That is not true. We see it worldwide. It may be a little variable, but risk is significant for everybody. Other one is I exercise and I eat healthy. I have no symptoms, so I never thought about doing it. We see the risk is multifactorial. You may be a super healthy eater, marathon runner, and we do see colon cancer even advanced ages and young ages in those individuals. So they all should be screened when eligible. So a lot of talking, but I will end my talk with this take home that I hope I was able to convince you that colon cancer screening is important, and it starts at age 45 in average risk individuals and sooner in high risk if you have high risk factors. And there are multiple colon cancer screening options out there, but colonoscopy is the gold standard for colon cancer prevention and detection because this is the only modality that can also remove polyps. If you are not excited about colonoscopy, the stool fit test and stool Cologuard are great options as well for you. Simple, easy stool test can be done for average risk patients for screening purposes. So please consider them as well. And if I get asked what is the best test, I will end by saying the best test is the one you will do it. Just do it and do the follow-ups and get screened. So with that, I will end my talk. And, we really appreciate you joining us, and feel free to enter your questions in the chat box, and we will be more than happy to answer those.
Yes, and to get us started, I know we had some questions that were submitted to us in advance. We've also had people adding them as we're talking, which is great. So we'll do our best to get to all of those questions that we can. So just to get us started, some of these questions have been asked before or addressed in the talk, but I might just ask just because not everyone might have been here from the start. So just to summarize with the colon cancer recommendations, if someone has, Lynch syndrome or extended family members with colon cancer, not necessarily a direct relative or maybe a personal health condition that they're concerned about, what would you tell them in terms of timing on when they should have a colonoscopy?
Okay, I guess I can answer that. So, Appy, that was a great talk. Thank you. You really answered just about all these questions in advance, but just to go over things. So, obviously, when you meet with your provider, you want to whatever extent possible, individualize or personalize your risk and have a discussion about the different screening methods. And one of the most important parameters in terms of personalized or individualized risk is family history. There's no doubt that when you have family members that have colon cancer, that increases your risk, or even family members that have large polyps. And the closer the family member is to you, we call it a first-degree relative. If it's like a sibling or a parent or a child, that conveys a higher risk than a aunt or uncle or a third cousin. So it's the closeness of the family member, the number of family members you start to accumulate. Is it just one family member? Is it multiple family members? And then what's the age that the family members had the risk? Because colon cancer, as you heard, is very common. So having one, cousin who had colon cancer when they're 85, that probably doesn't change your risk. But having a sibling who had colon cancer when they're 35, that's going to dramatically elevate your risk. So when you talk to your provider, you want to, as much as you know your family history, that's a problem. People don't always know all the details, but to the extent possible, you try to get that family history and convey it. And when there is an elevated risk because of family history, it tends to make the colonoscopy the preferred screening test, because there is a higher risk that there'll be lesions. In some of these syndromes, like the Lynch syndrome, the way the lesions grow and where they grow makes it harder for sort of the non-visualized tests to find the lesions. The lesions can kind of go more quickly from the precancerous polyp to cancer in some of these family situations. And so hopefully your provider is aware of all of these things, and that's going to kind of set the age at which you start the screening, what is probably the best screening test, and how frequently you need to get the screening or surveillance test. So Lynch syndrome is an extreme version of that. Most people with Lynch syndrome have multiple family members with cancer, especially colon cancer and early onset, but not always. Sometimes you're the first person in the family to have Lynch syndrome. The family history isn't always so clear, but if you are known to have Lynch syndrome, meaning you've been documented to have a genetic mutation that is associated with Lynch syndrome, or it's highly suspected that you might carry that mutation based on your family history, then you're going to definitely want to get a colonoscopy. You're going to start it early at age 20 to 25, and you're going to do it frequently. As Appy said, every 1 to 2 years. It's possible sometimes you can be in a situation where you can do it a little less often. So family history is the critical thing to work out.
Got it. Thank you for that. And then there was also some questions about who decides what bowel prep you get. So is everyone able to get the pills for prep? Does some people need to do more of a liquid prep? What would your recommendations with that be?
As the gastroenterologist, I'll take that one on also. So the most important thing is that it's a good prep, because there's a very clear and very tight correlation between the ability for colonoscopy to do its job and for the endoscopist to do a good job and the quality of the prep. And in fact, if you come and your prep is not good, the colonoscopist has to make a judgment about, should you repeat the exam? Should you repeat the exam immediately? So you want to do a prep that's good, and that means being able to tolerate the prep. There are a bunch of prep options, and the lower volume preps are definitely easier to tolerate and appropriate for most patients. So that's definitely an option to explore. The other thing is how you do the prep. We now do this thing called a split prep, which means you have to do the prep in 2 parts. And that definitely, it's important to do that if at all possible. It definitely leads to better preps. One of the preps that is kind of popular, because at least it has the perception of being more palatable, is the pill prep. And that one can be a little dangerous for people that are older or have kidney problems or heart problems. So again, you may not be eligible for the pill prep, but those low volume preps, usually you're going to be eligible. And then there's other factors that come in, like, do you have a history of constipation? Do you have other conditions like being having a little higher body mass index, or being on drugs that slow your bowel, things like that. So the practitioner or the practitioner's office should help tailor the prep to some degree so that you have the best possible prep. And then there's insurance issues. Sometimes an insurance company will only cover certain preps and not other preps, but the preps are not that expensive. So if you have a preferred prep and it's not covered, it's not a huge expense. And it's, of course, only once every 10 years.
Got it. And then a question I might ask to a couple of you is just, do we have any idea why colon cancer incidents are on the rise? Is that a lack of screening? Do we think there's something else going on? Any guesses there?
Well, I'll take. I don't think we really know. We think that I mean, I think there's a lot of theories about dietary exposures that are more common. There's a theory about plastics in the diet causing problems. It's not due to lack of screening, because people under 45 never received a lot of screening. So there is something happening, and it's happening globally, and we don't know yet. I don't know what Jonathan would say about that, but
Yeah, I just want to add that we have actually done a really good job of reducing colon cancer incidence and mortality in older people. So screening, even though you saw Dr. Singh point out that screening rates are far from ideal, which is true, we're still not doing as well as we'd love to do, but even doing as well as we are doing, the rates of colon cancer incidence and death in the population are dropping overall, and definitely in older people, because we would assume that's screening. But now we have this new problem, which is colon cancer occurring in young people. Now, as a total burden of all the cancers, it's still a small number. So again, most colon cancers happen in older people, and people's risk when they're 25, 30, 40 is still low. So people shouldn't panic about this. But it's on the rise. We don't actually know. It's had some impact on the recommendations about when to start. You heard starting at age 45 now instead of age 50. I think the most important thing, which Dr. Singh did mention, is there used to be a thing where it's like cancer is so rare in young people that you could have symptoms that are indicative of potentially cancer, the kind of symptoms that would make you get a test right away if you were 60 years old, and that would be blown off when you were 25 or 30 years old because the doctor's like, well, it can't be cancer, it must be a hemorrhoid or something innocent. And that's the main teaching is no. If you have any of those warning symptoms, even when you're young, you have to have a colonoscopy. And I would say that you should do that even if the symptom isn't persistent. So you should have a very low threshold if you do have those classic symptoms. And that's kind of new. We used to say, no, you're young, it's okay if you have a little rectal bleeding.
I think there is a little bit of nuance there because the most common cause of bleeding in a young person is hemorrhoidal bleeding, probably. And it's possible to diagnose hemorrhoids in a clinic, have someone look and see and treat and see if you don't necessarily if you have bleeding that's from a hemorrhoid very clearly need to get a colonoscopy. In fact, I think I've sent people to Jonathan with that reason in the past. And he said, why did you send this person when they clearly had hemorrhoids? But the point is really well taken, is that the biggest problem is that patients are not aware, people are not aware that the symptoms could be cancer. I think that's the biggest thing is the most common thing is someone is living at home with symptoms and assumes that it's nothing to be too worried about and they don't want to go to the doctor and they aren't aware that this could be a problem. So I think people with unexplained abdominal pain, unexplained rectal bleeding that is reoccurring over a period of weeks or months, those are reasons to go and see the doctor. And I think we also still have a lot of work to do to educate primary care doctors who still are not always aware of the potential uh, things that could go wrong by not evaluating blood in the stool. And I think especially if you have a family history, if you have any of these symptoms, it's really important to get evaluated. So that's unfortunate for right now, that's the solution that we have for younger people who have a low rate of colon cancer, but it still is going up, is to really attune people to their family histories and their symptoms, because that is one proven way to address and reduce that risk of death from colon cancer.
And we are recording this webinar, so Appy had addressed some of those potential symptoms to look for earlier on. And then we are getting close to time, I know, for this event. So any final words of advice or tips you guys would want to share with people about colon cancer risk and what they should be doing to stay healthy?
Thank you, Sarah. Well, I'll just say, I'm sorry, I do see that there are some other questions here as well, but I know it's late in the evening and I do want to be mindful and respectful of everyone's evening time with their friends and family. So I just want to say really appreciate everyone joining us this evening. We will be recording this and posting this online on UCSF Lynch Syndrome Center website, and all the registrants will send out an email when the recording is posted. But I will end by saying that, get screened, pick a test that works for you. There are many options out there, and there is no reason anyone should not be screened or up to date on their screening program. So get screened. Thank you.
Thank you, organizers, and thank you, Appy, for that great session. It was awesome.
Thank you, Jonathan, and thank you, Mike, Amy, Sarah, for joining us as well. Wouldn't have been possible without all the prep and planning and help without your help.